Lovely. Hi everyone, and welcome to today's 10 Talks. We're joined today by Suzy, Cheryl and Lister, first contact practitioners, OTs from Northwich Primary Care Network, who will offer an insight into a role that is quietly transforming how care is going to be delivered and is being delivered in the community. With over 4 years of experience in this service, the service supports adults with both physical and mental health needs and takes a real proactive and preventative approach to care. If you've joined us before, you'll know that it's a 10-minute talk. It's recorded for the first 10 minutes, and then after that is open questions for you in the chat. Please keep your cameras off and enjoy a little sandwich or drink for your dinner, whatever you're having, and you will be muted for your microphone. So as I say, put anything in the chat. We've got Kerry helping us today with that, so any questions will be highlighted to me later. So welcome to today's 10 Talk, and we're going to jump straight in. It's great to have you with us. I really want to know, how did you get started as an OT in primary care, and why has this service been developed?
Thank you for having us. So before I saw the job advert for this role in Northwich Primary Care Network, I didn't even know that OTs worked in primary care. I think even now, and especially kind of 4 years ago, it was quite new. I think we're quite used to seeing OTs in secondary care services and inpatient services, planning discharge, but it was definitely a developing area back then. So when I started to look into it after I'd seen the advert, I got quite excited about the different possibilities for developing a service like that, especially tailoring it to the local area in a PCN. Our PCN, they were looking at different ways that they could use their R's funding for additional roles. I know they already had pharmacists and paramedics and social prescribers, so they were just looking at other options really, and different professionals that could have a different impact. So they'd already spoken to some OTs over in Leek that were already doing a primary care service, and they were really interested in what they were doing over there. They were working with patients with mental health difficulties, long-term conditions, fatigue management, and they really saw kind of the potential to use a similar model over here. So that's how we got involved.
And like it's so nice to hear like places are learning from other organisations and other regions then to understand how they could transfer that model. So why is the OT role becoming increasingly important in primary care?
Yes, as you say, I think now there's more of us around the country kind of doing primary care. We really are kind of learning from each other. And then particularly with the NHS 10-year plan and this move towards kind of neighbourhood health services. So that kind of community working and in the local area and being more accessible to patients. I think OTs in primary care just really fit really nicely into that. So we do home visits. We'll see people at home in their own environment, but we'll also do clinics. People will come into the GP surgery. We try and make our appointments as accessible as possible. And obviously there's just an ever rising demand for primary care and GP services. So we're very aware of that. And I think we have that opportunity to see patients outside of that kind of 10-minute, GP appointment, and actually look at a more holistic assessment, look at their physical health, their mental health, how those two things are interacting, their social environment, their home environment, and we can really try and kind of unpick that and support them to manage their own health and well-being and keep them as independent as possible for as long as possible, really. So the idea is to try and reduce those referrals into secondary care and support them at primary care level.
Yeah, and that is just key, isn't it, with all the neighbourhood integration work that's going on at the moment. And, to think of that holistic care, absolutely patient-led care, there's so much to learn then from an OT role that can be put into other roles within the NHS, I'm sure, because holistic care is absolutely up there, isn't it, on how best to look after a patient. So what pressures or gaps do you think that role helps to address?
So as Suzy said, we cover a whole load of different settings, from doing home visits as well as clinics, as well as visiting care homes. So from a memory perspective, we can complete holistic assessments and then refer on as appropriate to the memory service, to more specialised services. For care homes, we identified that there was quite a big inequality of care for people in 24-hour care settings. So our aim is to try and reduce that inequality and give them the same access to our service as they would if they were living in their own home. We can complete and take on fit notes for patients who are in employed work. So we can support those individuals who are in work and want to get back to work, but for whatever reason are having difficulties with that, and help them and support them to get back into work, and link them with services and support groups in the community that can also give a wider aspect of their support to get them back into employment. And then from a long-term conditions perspective, especially patients with fibromyalgia or multiple sclerosis, arthritis, we can look at managing their fatigue and think about, their exercise tolerance and anxiety management, and what we can do to really improve their everyday activities of daily living and give them more confidence and independence in that.
That sounds like an amazing opportunity for the patient, not to have to go to so many different services to be, to have those things looked at. It sounds like an absolute massive breadth of types of patients that you would then cover. So can you share an example, I suppose, making it real for us, how an OT a therapist or service has made a real difference to a patient, to either their independence or quality of life?
Yeah, so I've got an example of a patient that we worked with in a care home setting. She was a lady who'd been a resident for quite a while and was choosing to remain in her own four walls of her room in the care home. And she would sit, eat, live in her recliner chair. Her legs were becoming very ulcerated and edematous. GP was running out of ideas of how to support this lady. District nurse and tissue viability were visiting on a regular basis. Patient had full capacity, knew the risks involved with staying in the armchair, but had no wish whatsoever to go onto the bed, as the health professionals were advising, to help manage her condition. So the GP referred her to enable us to kind of explore the reasons why she didn't want to go onto the bed. So we met with her, had a good chat, tried to explore what the concerns were. And it turns out that she was actually just really lacking confidence. She lacked confidence in the staff, that once she was on the bed, that she would be able to get back into the chair, that she wouldn't be stuck there. She felt quite anxious about being in bed because it stopped her from being able to reach items that she wanted or needed because she had reduced range of movement of her upper limbs. So that was why she chose to remain where she was, because it gave her a better quality of life in her instance, even though she was at risk of losing her legs long term. So we started some anxiety management techniques and worked with her and the care home staff to gradually increase her confidence to go onto the bed, just initially for 30 minutes. And then get back into a chair, and slowly over a period of time of us monitoring and supporting the staff and with the patient, and letting the patient know that she is empowered, that she has the ability to request these things and for them to happen. We just enabled that process to happen, and I'm really pleased to say that the result was that she was able to then access her electric powered wheelchair. She was accessing the dining room, going to activities within the care home long term. She was then able to go out with her family. So she wasn't stuck in her room. She could sit in her recliner chair as she loved when she wanted to sit and relax. But most importantly, she was then sleeping at night in her bed, and her legs are unbelievably different. So she was discharged in the end from district nurses, and quite soon after she was lying in bed from the tissue viability nurses. So yeah, a great outcome for her with just that little bit of empowering and support. It made a huge difference to her quality of life.
And probably not just even that person, a family that were really probably worried about her. They could, the wider implications of that is massive, isn't it? That is such a phenomenal story, and one that I think needs to be shared wider than this 10 talks. That's absolutely brilliant, and what a great demonstration of how it can actually really make a difference. And like you say, when people run out of ideas, that's because they're seeing it from a different perspective from you, trained as OTs. It's totally different, isn't it? You know, the way that, and I suppose, that you view what can possibly be done.
Just
Amazing.
having that time just to talk to them and yeah,
right,
find out the reasons. Yeah,
I love that. So how does having an OT in primary care support those other professionals like GPs and nurses and social prescribers? We touched on it a little bit, but how do you think that it helps?
Yeah, so it really does help. I'll just have a slide on the outcomes. And if Kerry is able to
Kerry, please. Thank you.
So basically, having a primary care occupational therapist in the GP surgery, it does really it does help. As you see on the snapshot of the cognitive screening clinics and also the housebound cognitive screening, it's just a part of the service. And you see, like, for example, in 2023, 209 patients were assessed in the primary care occupational therapy clinic, and 51 were assessed at home. We're also having a cognitive decline. And from adding that, you can see on that component only we saved 260 GP appointments, which then opened for other things for the GP to look at. And when you see that, when you look at that graph below, having a first contact practitioner occupational therapy in the surgery, it meant patients could be booked straight to the clinics for their cognitive decline. Then the assessment is done, passed it to the mental health, with the GP, of course, analyzing the memory screening bloods. Then what we got an update from the psychiatrist, they were saying they were giving their patients quicker diagnosis. It was a quicker pathway for the patients. Hence, picking those who could be suffering from Alzheimer's disease, it meant they could be started on their medication to slower the process, which really does help. And also working with other team members in the surgeries, we tend to work like with paramedics, nurses, we have the clinical pharmacists. So there is that multidisciplinary care of that patient. We refer to them and they also refer to us. We also refer to the community team members, which really quickens the flow of patients seeing. And we also work with social prescribers, which after the pandemic, you are aware social isolation was a big thing. So our social prescribers, when they're involved, some cases, they have to also refer to other team members, including us, the occupational therapist. That means quickening the pathway. And also us being on that role, it means we can also support the social prescribers with supervision on the cases they see.
It's amazing. So not only are you developing social prescribing link workers, but you're reducing it as in the 45 days reduction in weight. That's over a month. That's nearly a month and a half, isn't it, of not having to wait. So I'm really conscious that we're over 10 minutes. So I'm going to stop us there, but I'm going to continue to ask our questions. If you could stop recording, Kerry, that would be fantastic. So our last question that we had was that if someone in primary care is unsure whether to involve an occupational